economics is a very important issue at the very moment. The Greek and the Germans, they can tell you other stories about that. And what I heard, and to be very honest, being a flight chief for more than 20 years, it's a discussion of private emergency services. So I'm really interested to hear what is the idea behind that, and what is the experience our panelists may have. And of course, also the citizens, they have a certain expectation. Many of them, they are fortunately not forced to face an emergency, but when there's an emergency, they expect that they get help in the most efficient way. And this gives me the chance to ask some questions which you see on the slides. Okay, I have to do that. So I thought as an operator.
We will share.
I must not repeat these questions here, but I want to ask Martti. You did I think what we learned, you did a very straightforward approach, you may think. The emergency services may think in a different way, but when people ask you on EU level, is that a model for European Union? What is your opinion?
Thank you for, sorry, do you hear me? Oh, thank you for asking me that. I think it should be the right way of harmonizing the European emergency services or response center services. But I know, especially after the previous presentation, there are huge cultural differences between different European countries, and it takes time. And I guess we have to do it by stage. But I think the way we have chosen is at least the best for us and the Nordic countries.
Okay, that gives me another question. You know, these questions are prepared by our EENA staff, and I learned that there are KPIs. Could you imagine to have KPIs in Romania, or do you already have these key performance indicators for an EU-wide
I think
comparison?
That we should have, and I think, yes, in Romania, at least partially, yes, there are key indicators for certain points in the emergency service where we look at in the emergency system. But I think that, yes, we need to have indicators, we need to have limits, we need to know what is acceptable, what is not acceptable. We need to be able to compare each other, because the indicators allow us to compare the services and see who's doing it in the best way, and maybe taking from them the good experience. So yes, we need key indicators in Europe that we can compare each other on our work, and we can develop based on that.
Okay, one question to Richard. Key performance indicators could be response time. Incoming call until you dispatch, or until you react and you alarm. Do you have something in place in London at that moment?
We have a number of indicators, and I think probably the UK system probably got too obsessed upon time and not on outcomes. There was a change last April where they now have a balance, so every trust is obliged to report on response times by different categories, and for us it's 8 minutes. So for seriously injured patients, we get 8 minutes from when the call starts for some cases, and from others when we get the basic information. What we also report now is against about 12 other indicators, which are things like cardiac arrest survival rate, how we treat stroke patients, and again things like stroke care has been a massive improvement in the UK. And what we've done is it's not just about how fast we get there, it's what we do when we've got there. So for example, under stroke we have time targets to get the patient to a specialist stroke centre, so not the local DGH, the specialist stroke centre, where they can be scanned within a very short time period, and if they do have a clot they're then thrombolised. So it's a whole system target that we have. And also from the ambulance perspective, we have a set of key measures that we have to achieve. So the clinician assessing the patient must do a certain amount of things, which is standard across the UK. The figures go in the following month and then reported on the Trust websites and the Department of Health websites. So you do have proper national reporting. That covers other areas such as how fast you answer the phone, how often you don't get to answer the phone, because there are times when you get peaks in demand, you can't answer the phone as quickly as you like. So they measure the abandonment rate of calls as well as how quick you answer 95% of the calls. So it's a whole range of balanced scorecard, really, KPI. And I think that's quite a big improvement.
Okay, just one explanation, please. Response time 8 minutes, that means the overall response, the attendance time, or what do you mean with this response time? It seems to me that response time in the PSAP would be very long for 8 minutes. That's okay. Not what you mean.
No, for cardiac arrest calls, which are categorised as the highest, it's from when the person dials 999. So the second the call is put through to the operator from BT or Cable and Wireless who handled the initial call, the second it's put through to us, the 8-minute clock starts. So we have to take the calls, take initial information and dispatch whilst we're still taking the call. And it's not uncommon for us to be dispatching within 20 seconds of connect and actually having a resource on scene 2, 3, 4 minutes. Mm-hmm. That's quite common. And we've seen big increases in cardiac arrest survival rate as a direct result of that.
One question to Dimitri concerning these KPIs. I think there's a difference. There should be a difference between such performance indicators in the PSAPs and in the emergency services. And when you come to emergency services, that's very much depending on the country. Have you have very rural areas on the coverage with, with ambulance services and so on. So, do you think that these performance indicators concept has a chance?
Well, there are two things that we need to realize about key performance indicators. They're very good, but as with all statistics, it depends what you put in them and what you get out of them. For example, since you said, you mentioned about PSAPs and emergency services, we still cannot come up with a ratio that we can all agree about how many citizens per ambulance, for example. Is it 40,000? Is it 20,000? Is it 25,000? So as to be able to have the same type of groundwork in order to have the KPIs. And the details are always, the devil is in the details about KPIs. But the other important things is that key performance indicators sometimes might be a trap. And that trap is, I'm doing a good work because I have KPIs, therefore I don't need to change anything. And as Raid said, we always need to look for change, even if we have good KPIs, because the challenges that are ahead of us cannot be solved always with the answer, but we have very good KPIs. And one discussion to move forward is public versus private. Public versus private, which is a topic that we're discussing, if both have the same key performance indicator, does that mean that they both doing the exact same job? Does that mean that they can be adapted at the same level of adaptation? So I'm all for key performance indicators as long as we understand the general implications about them. And I'm sure that Raid has some interesting views about private versus personal.
This leads us to the next question, but I just want to stay on that and ask Marty once more. Do you have key performance indicators which you present to, for example, to your emergency services that you say, so we have a reform of our system, and now the system is better? For example, because our response time to an incoming call is now much better, and so on. Do you use this type of justification, let's say?
Actually, you already answered. We do think actually that we have and more than 90% of the calls, for example. And I think it's very important to have that kind of indicators, especially for the ERCs or PSAs. And then the other indicators for ambulance services or police services and so on. We need them because we have to put pressure on politicians to recognize that the ERC work or PSA work is independent work, an essential part of their chain of assistance. So we need that kind of indicators that can show that we do it better, cheaper, and so on.
Mm-hmm. Okay, right. What is your experience in your country? Do you use that? What was the reason why you build up the system like you have it now in Romania?
Well, if we look at the last 20 years, how we built up the system, first we started with a pilot project, which was copied in several counties. And then in 2007, the government, the Minister of Health at that time, and the Minister of Interior, they requested that we go and spread the whole system in the country. So if we talk about the system, it's a fully integrated national emergency response system, which starts with the 112 and finishes with first responders, firefighters, ambulance, and so on. So the system was built. We had a huge change in the outcomes of emergency response, a huge change in the time of reaction, and we are still building on the system. And the experience we had is that from fragmented system that we had 20 years ago, where we had dispatches in every small town, we had that for fire, for ambulance, for example, a single county that now has a single dispatch with 112 and everything. Before, it used to have maybe about 21 dispatches, 3 dispatches, 1 for each agency in each of the major towns in that county. And then you would multiply this by another 41 counties plus Bucharest. And you can imagine what we had there. And each small dispatch was managing a small number of ambulances or a small number of fire engines. And once these were busy, they didn't connect to ask help from others. So we had long times of waiting and so on. So what we did, we started concentrating and integrating. And what I said before, since we gave to the fire department the task of doing first response, the fire department has 2 tasks in medical response. The first response and the joint teams with the most advanced intensive care mobile units, where we have firefighters and a physician and nurse from the hospital. So once we gave them this task, and we had the ambulance service of the Ministry of Health working also, we needed to integrate them to have a single decision and integrated manner of managing them. The other issue is we had a lot of problems with administrative areas. For example, each county, the ambulance service refused to go out of their administrative area. The fire service, which is a military status service since 1835, they wiped off completely the administrative areas, and they go wherever they are needed if they are the nearest. So it took us some time to start taking out the ambulance service from their administrative area to respond if they are the nearest, and many other issues. But I think the key in our success was the integration of the services, that we succeeded to have a single number all over the country, which is the 112, that we succeeded to make the state responsible for all this. We have a law which writes about emergency medical care, that emergency medical care in Romania is the right of every citizen, and it's the obligation of the state to deliver it. I don't know how we escaped with this in the parliament, they voted it, but once it was voted this way, we used it a lot to push the system ahead. A lot of the system is funded through, we will talk about funding through state budget and not through insurance and other ways, so that we guarantee that the system is working. Air rescue also is fully integrated between Ministry of Interior and Ministry of Health. We don't charge money for the patients. We don't take money from insurance. It's a state budget which is funding that service. So I think that these are the issues which we did in our emergency system.
Okay, thank you for that. That leads me to the next question, private versus public resources. Dimitri, could you say something about that when I'm thinking about the state fire service in Greece? So I cannot imagine that to see them privatized.
Yeah, that's an interesting start because in Greece we have one fire department service, one ambulance service, and those are statewide, and one police service, again statewide. The chance to see a private fire service and a private ambulance service came when the new international airport was built in Athens, because they had to have their own fire department and their own fire service. And they actually started a bid about finding fire service and ambulance service just for the airport itself. They ended up stopping the bid and giving direct contracts to the fire department and to the ambulance service. And that solved that problem. But the discussion in Europe is there about private ambulances responding to emergencies and about health issues being dealt by given to private companies that are doing a good work. But you have to realize the implications behind that. Like what Raid had, we need to find out a fine line that it should belong to the state, in my opinion. And I'm sure other people have other opinions, but to give you a very brief example, if somebody has a heart attack right here, right now, he would be willing to give everything he owns to have the best treatment ever. And his flexibility is zero right there. Now, I can think of persons that are willing to give everything they own to look better in their face. But these two people are not the same and shouldn't be treated the same, because the guy who's down at the floor willing to give everything, in reality shouldn't be worried about how much he needs to pay to save his life. Whereas, I'm sorry, I don't have any sympathy for the person who needs a plastic surgeon and is willing to share everything he owns to look better. Now, I don't know if that is an example that we can all understand. But the elasticity in terms of statistics and management that the person with a cardiac arrest has is practically zero. So we shouldn't be discussing about him if he should get private or public. It should be, as Raid said, his right to have the best medical care provided by the state if he needs a real emergency. If he needs a medical transport, that is a completely different story. If he needs somebody to pump out water from his house, we can think about it. But I think there should be a fine line that distinguishes public and private.
Okay, do you agree that, to my opinion, it is an idea just to have the private companies doing the emergency call taking and dispatching, but the other parts of emergency services, that means ambulance, fire, police, should be up to the state? Or do you see that it's open for the further development, that every service can be privatized in the future?
I don't see it exactly the same way. You say some of the services could be privatized. As you mentioned, some ambulance services, transporting, etc., can be carried out by the private companies. But if we use private, for example, private ambulances, the requirements must be the same as we have for the public service. And from the point of view of the citizen, he or she shouldn't see any difference between whether it's a private or a public service. But otherwise, I see the trend of privatizing when we talk about the response center, emergency response center services. It's something that it's very difficult for me to understand at the moment.
Okay, Richard, is there any movement in the UK to that respect? Private companies doing the job?
There's a lot of talk in the UK about any willing provider. I take and support Dimitri's point really is that I think in terms of low-grade transport, outpatients appointments, so forth, is absolutely fine.
Okay.
I think what we found, particularly in London, is there's a number of private companies that have come in the market, lost money, gone under, moved on to the next one. So I think the patients got quite a poor level of care. I think the regulation needs to be tight. At the moment, paramedics themselves are regulated, but all the lot below, the groups below, emergency care support workers, technicians, there is the very grey area here, and people we would have spent 3 or 6 months training, a private provider can often put them on a much shorter course, call them the same thing, and I think the levels of care are very, very different. So I think for the emergency 909, 112 system, I think absolutely that should stay within the state. Some of the inter-hospital transfers and other things, yes, I think there's flexibility there. I think you also have to bear in mind, and we look back at incidents that have happened both in London and around the world, is actually it's very hard, I think, to pull together in a major incident scenario 8, 10, 15 different providers to corral together to provide a consistent service when actually you need to have it under control of one. I think those are the times where you will perhaps have moved too far down the path and then realise actually you want to go back to an integrated system.
Right, please.
I think that it's a very interesting discussion. It would take a lot of time to go deep into it, but it's not the issue if they do the same service, then they are equal. In Romania, when we did our legislation in 2006, we were aware of these tendencies, so we wrote in the legislation some very strict issues. For example, public funding goes to private sector only for transport and for house visits, but not for emergency care. We allowed the private sector to exist because it existed at a certain time. They started evolving. If someone wants to pay them, I want a private ambulance to come, okay, I will pay them. Their problem, in fact, became that the public services became much better than them. And people started stopping calling them after 2007. So what we had is a huge attack on the public sector by the private sector, where they used lobbying, they used politicians, they used everyone to open the market, as they said, and to diminish any regulation that exists in the law, so that it becomes a pure competition on public money. Every few years you do a competition and then someone wins and someone takes over, and after 4 years, and this model exists already in Europe. And this is where we started fighting it a few years ago. So what happened, and I will show you how it is working. In 2006, when we wrote the law, we had huge debates, and then we had the support of the ministers, and we succeeded to go just to allow them to go into the transport and to the house visit. In 2009, they took us to court, first to the appeal court. We won, and they were invoking that we are discriminating them, that they have the right to do the same work as we do using the public money, and that in fact the state is subventioning the public services against the interest of the economy. So, and these were only some issues in there taking us to court. So we won at the appeal court. They took us to the constitutional court. At the constitutional court, at least 3 issues were underlined by the court. Public state services and private commercial services are not equal in front of the law. And there's also a certain European Court of Justice resolution which says the same thing. The second issue, we cannot talk about subventioning and in, let's say, having an implication on the economical market, because the two services are totally different. The public service is doing a state mission. It's not involved in the economical market, whilst the commercial system is a commercial system. Yes, it is involved in the economical market, and this is something else. Then about the discrimination, they said as long as they are allowing you to work, the state is not forced or obligated to fund you as commerciants. The state can decide not to fund you. So they told them that the law is constitutional, and they refused there. So what happened after that? We didn't stop there. In 2010, there was an attempt to change the law by a member of parliament who came with a full new written changed law by a private ambulance company, which really rose a huge discussion in Romania. It failed. Then in 2011, there was an attempt to change the whole health law, and there the attempt was the following: wiping off all the legislation which we wrote that it is the right of the citizen, that it is the duty of the state, and all these issues, and putting only a single phrase. Emergency medical services in the pre-hospital are delivered by authorized ambulance services, period, and that's it. This would have opened the market for them. And then in front of the Constitutional Court and so on, then they would tell us, yes, it's authorized ambulance, so you will have to compete on the money and so on. The problem is that the money we have is so little, and it is barely funding a public system which is working well in an integrated manner. Once you open competition on the public money, where are you going to see your public service? It will start diminishing slowly. Within a few years, you may find yourself that you don't have a public service. Because the first issue that is done is dumping the prices. And there are huge companies in Europe that can do this for a few years, and they can really fund their loss for the beginning so that they gain afterwards. The second issue, you don't have sufficient human resources. We're not talking about increasing capacity. We're talking about who is going to take the paramedics, the nurses, and so on, and work with them, because their number is nearly fixed in the country. They don't increase every day. So once you do this, that means if they have more money from the public sector, they will take also your human resources. And this leads us to the other question. Our emergency services are not taxi services. They are services which do daily work, but they are always being prepared to respond for disasters, mass casualty incidents, situations like we had in the UK, in the US, or maybe an earthquake in Bucharest, which we expect to have thousands of injured. Can we give this in the hands of commerciants, which in the last minute they may withdraw? This is a big question that we need to put. And if we take the example of the Olympic Games in the UK, those who don't know the story, the security of the games were given to a private company, which then was replaced by the UK Army in the last 2 weeks because they couldn't do their job for £283 million. Then we go for another question. What is the interest of the commercial companies? It's to make money. Where do they make money? In urban areas. Are they interested in putting an ambulance in a rural area and just waiting for an emergency once every 2 days or so on? I don't think so. Or they will do it for a very high price. Because if you want to give equal care, you need to put fire engines and ambulances even in areas where maybe there will be one call every 1 week, but this is not the interest of commercial companies. Will they keep a reserve behind that you can call when you have a major incident? Yes, but for extra money. All these questions can raise. And if you have a good system, again, the question is, do you want what I did, and this is, I will finish, what I did when we were audited by the Romanian parliament on this, I put the following question. Are you ready to open for a bidding the defense of Romania and the policing work? No. I said, okay, when you open for a bidding the defense of Romania and you accept that a commercial army comes and defend Romania when it has a problem, we accept to open for a bidding the emergency service because it's equal. It's one of the national security systems. So you can open it and you can start debating on to whom to give it and to which company to give it and so on. There are still a lot of issues that can be said, but they are beyond the time we have now. But this is a very interesting discussion. I think that we need to go deep into it. It's not only the matter of if we do the work equally. It is also the matter who's responsible for this. Are we allowing the government to wash its hands, outsource, and then say they are responsible, they are being paid for this, and so on? No, we need to keep our responsibility and to be accountable to what is happening with our emergency services. I think so.
Okay, I think everybody was nodding, so the panelists are saying, oh yes, we underpin that. So, but Richard, the consequence is not to say if we do not want to privatize everything and that we ignore the budgetary impacts we have at the moment. Maybe Did you react on the financial crisis in your organization to find different ways to reduce overheads and something like that?
I think one thing we need to look at, and picking Dimitri's point before where he said how many ambulances do you have per head of population, I think the problem is that you can't have a standard because it depends on where your system is. We have very much a free to any provider system, and I think what we found is over time the ambulance service and the other emergency services in the UK have really become quite abused by people with quite trivial complaints calling. So I think the question for me is not is it private, is it public, it's how do you deal with the demand that comes through your door. London's got a population of 8.5 million in total, including people working there. We're seeing about 1.7 million emergency calls a year. That's quite high for a proportion, and you can't keep sending an ambulance to every patient. So we've invested quite heavily in clinicians in the control centre who are now ringing a number of these patients back each day and saying, actually, let's talk through what you've got, and do you need an ambulance to come to you and assess the patient? Actually, no, you need to go and see your GP, you could make your own way, etc. So we're seeing now in the UK, certainly in my trust, probably around about 6 or 7% of the calls we get through the system, we now deal with on the phone and close the resolution there. So it'll be interesting to see in the future, looking at the model shown before about the system was who takes the call, you dispatch the ambulance. The next question has to be, why are you dispatching an ambulance? Is that the most appropriate resource? There's 2 people dispatched is far more expensive than 1 person spending 10 or 15 minutes on the phone doing a more detailed clinical assessment. And I think that's where the debate needs to go in terms of what is the right response. So it's not just let's send as quickly as we can, but send the right thing to that person. In a rural area, again, it might be a community paramedic who could go and see that patient, treat them at home, manage them out of hospital. So I think probably we need to be investing far more in working on the phone, actually resolving what we have, rather than just immediately sending.
Okay, thank you for that. That leads me to technology versus human. You see, however, if you rely on technology, can that mean that the human decision-making is lessened? You already answered that to some extent. What is your opinion? Is it really necessary? And this is, I think, is the bridge to the previous discussion. Do the operators in the PSAP, do they have to have certain experience in the field, for example, as a medical emergency responder or something, or is that only to be good in handling the computer system?
Well, I believe that they should have some knowledge, any dispatcher should have some knowledge of field work, no matter what. It's a completely different work, I agree with that, and it's also a very specific work, but I think you should also have the perspective of the field, either during your training or even in some sort during your working time, to have the perspective of the field. And I think that's a very important addition to the calculations that you do need to make into your brain when dealing with a call. The other thing is, talking about human versus technology, I'm very much in favor of technology, but then you have to qualify that without excluding the human factor, because then we're going into something else. Before technology, the emergency services had protocols. And in reality, protocols are technology algorithms. So what has happened in emergency services is just that protocols, which were algorithms, were turned into technological products. I don't think there is another change. It's just this. It's something that you had as a protocol in front of you is now in technological terms, and that helps immensely. The trick is when you rely only on technology and you have no way out for the human intervention. One of the discussions, to make the point and stop there, is what happens when the protocol tells you you have to answer yes or no, Otherwise, I'm not showing you the next screen.
Okay.
And the answer is maybe.
Thank you for that, Marty. How do you solve that problem in your organization? I think, am I right that you have civilian workers in your PSAP in Finland? And how do you solve the problem that they have to have some experience? It's a matter of training of the operators. Do you use the protocols and they rely on what the system gives back, response, or do you give them additional training also in that, for example, as a medical emergency responder?
Yes, thank you. As most of you, I guess, know, we have an independent body. Our agency is an independent state-run body, and we have own staff which is educated. They have about a year and a half long education, and most of their background, they mainly come from the different services, nurses, police officers, and so on. So they have that experience you mentioned earlier. I think very much that the most important factor is our staff personnel, and technology in different forms is just a tool. Mm-hmm. And we always have to remember it just helps us, but it doesn't solve any real problems if we have them.
Right, you want to say something?
Yes, I think there are two issues here. I agree that you still need the human factor, at least for the moment, so technology can help but not replace completely. They tried it in Bucharest to put a system which selects the ambulances and so on, and what happened is that some person who needed to follow it up was sleeping and was leaving the system to do it on its own, and it was a mess in the Bucharest ambulance service in the 90s. So you need to have both of them, but technology in the emergency response can be very helpful, and here I want to underline telemedicine. We use telemedicine a lot in Romania now. Mm-hmm. And this comes to what our colleague said from London, because we have now over 1,200 ambulances which have real-time data transmission, and part of them are having video also. So for the dispatching system, yes, this may be extremely helpful because it helps us to decide on the resources we are sending. If you send the basic resource and via telemedicine you see that the patient doesn't need anything else, you are not sending any more a heavy resource, let's say, there, or vice versa. And also on the evaluation of the response, if you are having video and so on from the scene of an accident, maybe on the dispatch, if you have the experience, you can decide here we need to do this, we need to send more, and so on. So technology can be very helpful as complementary, as a backup for us in the dispatch.
Okay, another question, when you do, for example, the telemedicine, so who's receiving the information in the PSAP? Is that a medical doctor, and he will give advice, or?
We have two models. The one in Bucharest, where in the PSAP we have a doctor in the fire department, and they receive about 20,000 transmissions a year. So nearly every few minutes there is a data transmission from a fire crew, from the ambulance or so on, that is coming. Then we have another model where the transmissions are not so many, where they are connected to the emergency department. And there is a doctor in the emergency department who can see and then decide if further help is needed. What we had as a huge help here is with the diagnosis of myocardial infarction. Because once we put the diagnosis of myocardial infarction, the decision is always take the patient to the nearest cath lab if it is in the area, Don't stop in the nearest hospital, go maybe 10 minutes more and drop the patient where the patient needs to be dropped. Or maybe send a helicopter, pick up the patient if they are in the rural areas or so on. So it is a cooperation also between the dispatches and the emergency departments.
Is that model also used in the UK?
No. I think you should train your staff to do it. So all our paramedics are trained to read a 12-lead ECG. They make the decision and they decide where to take the patient. The same with trauma and the same with stroke. So we actually rely completely on their judgment to do that and incorporate in their training. Because I think there is an inherent delay built in. There are cases where you get a complex case you need to deal with, and I think what we do is we have more experienced clinicians based in the control centre with medical backup. They can provide additional support if needed, but the actual bulk of the diagnosis is done directly by the crews, and we don't transmit the data. We take the patient and hand them over.
Okay, that's very interesting. For example, in Germany we are we face the situation that in the eastern part, we don't have enough emergency medical doctors anymore, and we are thinking we have some projects running that we provide this telemedicine especially to these areas. Would that be a solution also for Greece, do you think?
The problem in Greece, like in some Nordic countries as well, is too many islands and too many small islands with only rural doctors, and or even just a few people with no doctor, and that's where telemedicine becomes really important, and today's technology, telemedicine can even mean just taking a picture of an ECG and transmitting it to another center. So the more technology is advancing, the less telemedicine means something specific. It means data transmission in whichever way, and now there are so many ways to do that. But it's also a part of discussing two different systems, and just to clarify, there is the mentality and the system mostly used in Europe, whereas medical doctors are involved in the pre-hospital care. And then there is the system mostly in United States, UK, and Holland, where medical doctors staying behind hospital doors, and there is only paramedics that are doing the pre-hospital work. We're not going to solve that problem here, for sure, but I just don't want to highlight that these two systems have different solutions to different problems just because they're two different systems.
Okay, I think the conclusion is it's an added value. In some cases, it's maybe the only way out to use the technology. Okay, that leads me to the question, financing 112. So you see in some sense they charge for search and rescue related services, in other countries not. So, and we have one colleague here from the UK. The services are financed by taxation, by taxpayers. So the question is, how is the situation in Romania? Is that a solution, or does the state pay?
No, 112 is totally funded as a system by the state budget.
Okay.
The emergency response system, if we take the fire department, it's funded by the state budget, by the Ministry of Interior, but they receive some funding from the Ministry of Health also, indirectly, for the medical part that they are doing. Then we have the ambulance service, which is recently we took it to the state budget. It was before funded by the insurance. Now it's by the state budget starting this year, and they receive their budget through the Ministry of Health. And for rescue, search and rescue, and so on, there is no whatsoever intention to charge. The helicopter service, it is run by the Ministry of Interior, let's say helicopter squadron. They have a large helicopter squadron, so they are the ones who run our medical helicopters. They pay for all what is maintenance, running cost, and so on. The Ministry of Health pays for the doctor, the nurse, and the medical materials, drugs, and so on. So it's all a joint venture between Ministry of Health, Ministry of Interior, and the funds from both ministries, besides what we call the STS, the Special Telecommunication Service, which they receive directly their funding from the state budget to run the 112. And when I talked about telemedicine, I want you to know that also telemedicine is state budgeted and funded. We have also a big system between hospitals. It's all run as a backbone by the same agency which runs the 112 from all communication points of view.
Okay, I want the panelists to see. Okay, so we have 5 minutes afterward, then we have lunch for everybody. Would you please answer the first question here? Should the directive mandating the 112 be free of charge to the caller be amended and a levy be created for handling the call? Yes, please. Marty, sorry.
I think it should be free, of course, but if there's some kind of other kind of services, it can be funded by someone else, but actually this 111 service must be free and budgeted by the state or public service, public sector.
Okay.
Yeah, I agree. It should be free at point of access. I think what you have to look at a bit is that there are some aspects of the community that abuse the service and overuse it, and we need to do more work with the people that regularly call the service. But often there's mental health needs associated with that, so you probably need to deal with the patient differently.
Thank you.
Same here. The only comment I'd like to make is that we have to think of fining people for abusing 112 calls, and that's the only thing I would see as something charging for abusing the call.
Okay, thank you for that. I think we should have some questions allowed. Are there questions from the? Okay, over there, please.
You can take the mic.
Thank you. Where was the question?
Thanks. Question to Richard. In the UK last year, there was a very interesting series called 999 What's My Emergency, which I'm sure maybe you saw some of it. Just for the audience, it basically looked at some of the social trends in society in one particular region in England and the effect it had on the 999 services. I have to say I found it absolutely fascinating. You mentioned mental health just now and looking at alcohol problems. Have you seen any effect on the London ambulance service since that programme was filmed? Has that had any effect at all on the sorts of calls you're getting from an education point of view?
Good question. I don't think so, no. In the last year, we saw a 6% increase in activity, 999 calls. Overall, we actually went to about 3.5% more calls, and that's because we're doing more stuff on the phone. So I'm not sure what makes the difference. And I think there's been a lot of discussion over the years about public education programmes, and I think you can try and educate the public. When they're drunk and it's 11 o'clock on a Saturday night, they automatically think of calling for an ambulance. Do they think back to a TV programme they may or may not have watched a week before? I don't think so. I think you absolutely have to turn the demand off as it presents. And I think the police are in a very similar situation as well, where, again, the activity coming through the front door they can't deal with. So it's about accepting that the demand will still keep coming, but don't keep responding to it, but actually deal with it on the phone and turn it away at that point in time if necessary. It does cause some issues with some of the callers, but I think the public education bit, I think all that happens is when you try and educate the public, actually you push demand up. Because they then say, oh, I didn't know they did that, or I'll give them a ring, or you get the perception of, if I go to A&E by ambulance, I get seen quicker. So it's my way of jumping the queue. So I think what we have to do is say, you know, I'm really sorry you've had toothache for 6 weeks, but maybe go and see a dentist, we won't send you an ambulance. I just not, and you'll hear some more of this tomorrow, but some of the calls you do get just are unrealistic to send a response to. So I think you can do a bit on education, but I think the bit is us being more tolerant of saying no. And I think there are times when it may go wrong. And we've seen that. We've got a new system in the UK of 111 for non-emergency calls. And in fact, what's that done? Well, it's pushed our workload up, what a surprise. Because about 15% of their activity now bounces to us, which probably was unmet demand before. So I think all you try and do to stop the demand, it just goes up. So I think, for me, in summary, turn it off when it gets to you, rather than investing lots of money in public education, because I'm not sure it works in the end.
Okay, there was another question over there.
Yeah, actually, you just answered 90% of my question. It was about the same, how to reduce the number of malicious calls. So, did you ever try to forbid the calls without a SIM card?
Yes. Yes. We've had 2 or 3 cases. One where we've actually gone to court and there's been court orders stopping people calling for an ambulance. We've got a number of patients on our system who are only allowed to have an ambulance if their doctor approves it beforehand, unless certain conditions are met, because they'll ring us 4, 5, 6 times a day. So those malicious callers, yes, you can. I think one we went to court and took a court order out against a patient because of constant abuse, and it's not just us, the police have done the same, and so the fire service. We have one chap who regularly walks around London calling all sorts of different resources, and we can then get the SIM cards barred. It's quite difficult to do, and one thing we need to be quicker at doing, but we have done that before, and they throw it away and go and buy another pay-as-you-go SIM card, and it's free to access. So you can try and turn it away, but I can't remember the record, 30, 40, 50 calls in a day from one person we have had problems with.
Any other question? If it's not the case, I want to thank the panelists, and I'll let you go for lunch, and hopefully you will be back at 2 p.m. precise. Thank you.
Thank you.